Hello and welcome to the podcast. This month is Genetics Month, where I will be having conversations about all things related to genetics and breast cancer. The field of genetics is rather complicated, and I thought what would be better than having experts come onto the show to try and help us understand a little bit more about this subject. Now, it's understandable to think that if someone gets breast cancer, then the likely reason for this is that it is due to a genetics cause. Whereas in fact, only between 5 to 10% of breast cancer cases are linked to a genetic predisposition, which is quite a small number, so the majority of breast cancer cases are not genetically linked. In this episode, I'm having a conversation with Dr Munaza Ahmed, who works as a consultant clinical geneticist, and she and I work closely together. In this conversation, we get to understand more about how errors in the genetic code causes cancer, the different types of genes that are tested for breast cancer, and the implications it may have on other members of the family, including men. Yes, testing positive for a gene mutation can have implications on male members of the family. This is something we don't talk about enough. You will definitely learn lots of new information from this episode. So, let's get straight to it. Here is my conversation with Dr. Munaza Ahmed. Hi, Muna. Thank you so much for coming onto the podcast.
Thank you for having me.
So during this month, we are discussing all things related to genetics and breast cancer. And you work as a consultant clinical geneticist. Can you tell me what that entails?
So my work is mainly based in outpatients departments. We see patients who've developed cancer themselves or have a very strong family history of cancer where lots of relatives have developed cancer, in order for us to think about whether those cancers could have happened due to hereditary factors. And specifically, the type of factors we're thinking about in our clinic are genetic changes in genes which give a very high risk of developing cancer that can be passed down from one generation to the next. So in our clinic, we go through the individual's own medical history and take a detailed family history to assess whether genetic testing is likely to be of benefit or not to the patient. And the features we're looking at are the age of if the person themselves has cancer, their age. So we know that there is an association with a higher chance of carrying a genetic change if you develop cancers at a young age, for example, below the age of 50. Or if you've developed more than one primary cancer below the age of 50, that can be suggestive that there is a genetic mutation there. And then when we also look at sometimes the pathology of the cancer can be relevant, because we know sometimes certain pathologies link with certain genes. And then when we're assessing the family history, we're looking to see if there are clusterings of certain cancers in the family in relatives who are closely biologically related to each other. And if the types of cancers are perhaps cancers we know can be linked due to specific genetic changes. And in the case of breast cancer, we know that in families where there are also ovarian cancers, that is highly indicative that there could be a mutation in a gene.
You know, we talk about genes and genetics all the time. And at a very basic level, what is a gene?
Good question. So we all have about 21,000 genes. Half of our genes we inherit from our mother through the egg cell, and half of our genes we inherit from our father through the sperm cell. Genetic changes that we're looking for in our clinic, in the clinical genetics service, are genetic changes which are passed down from one generation to another through those cells. Also, the term cancer genetics can be used in oncology when we're looking at mutations within the cancer itself. That is a different form of genetic testing and it has different implications. So that type of cancer genetics, investigating changes within the tumour to help the oncologist determine what treatment might be best for the patient. And that's called somatic testing. What we do in the clinical genetics service is a different type of genetic testing. We are doing germline genetic testing, and the egg and the sperm are the germ cells. We're looking for changes which have occurred in the egg or sperm, which can be passed down, which lead to an increased chance of developing cancer.
So all cancers are due to a genetic fault, but not all cancers are inherited. Is that right?
That is absolutely right. So the underlying change in all cancers are that there are some genetic changes which have meant that that particular cell in whichever organ of the body, if we're talking about the breast, changes have occurred in it so that the controls that make sure that the growth of those cells doesn't go uncontrolled, those are lifted away when a cancer occurs. So changes occur within the cell such that a tumor arises and grows.
So we know that cancer is a disease that occurs because there is uncontrolled division of abnormal cells in the body. So we know that, the behavior of a normal cell is usually governed by processes that happen in what we call the cell cycle. And that controls how the cell grows and how it replicates and how it divides. And we know that there are numerous types of genes that control different parts of this cycle. And when a mutation happens, the gene actually stops working properly and it affects the cell cycle, which in turn can cause the cell to grow abnormally and cause a cancer. So in breast cancer specifically, we normally hear about the genes BRCA1 and BRCA2. What are the normal functions of these genes and why does a mutation in them cause breast cancer and others such as ovarian cancer?
The BRCA genes are DNA repair genes. That's their function in the body. And the reason that an individual who carries a BRCA mutation has an increased risk of developing cancer is because at conception, they have inherited a mutation, which means that one of the two copies of that gene is not functioning correctly.
So it's not working properly, basically.
Absolutely. As you've mentioned, our cells are dividing all the time. And in those cell divisions, mistakes can occur in the DNA. So the function of genes like the BRCA genes is that when those mistakes occur, they come along and correct them to ensure that the cell continues to divide in the way it should do. But if you're born with a mutation in a gene like BRCA, that protection or that function is taken away. And so you end up, the consequences, an increased risk of developing cancer. Now, sort of $1 million question in my field, particularly relating to BRCA1 and BRCA2 and other breast cancer genes, is why specifically these mutations in these genes, which are present in every cell of our body, why they specifically cause breast cancer. And that is an area of great research interest, which groups all over the world are looking into. As we can understand that, perhaps we can target biological pathways to prevent the cancer from happening in the first place. But at the moment, we haven't been able to clarify why specific cancers are associated with these genes.
If you have a mutation, somebody is found to have a mutation in either the BRCA1 gene or the BRCA2 gene, that person is actually born with that mutation rather than that mutation kind of occurred during that person's lifetime.
That's absolutely right. But what has occurred is that in a cell, for example, within the breast, a second hit has occurred to actually cause the cancer. So whilst they were born with a mutation in that gene, something has occurred. And again, we don't know exactly what causes that second hit. We know that environmental factors, of course, do play a role in increasing cancer risk, but we don't know specifically in an individual what causes that second hit to occur. But once that second hit has occurred to that gene, then the control of the cell division is affected and a tumor arises.
When people talk about a mutation in a gene, What does that actually mean?
Often in clinic, I get the impression that people think we're looking for the genes. We're actually not looking for the genes. We know that everybody, absolutely everybody, men and women, all carry 2 copies of the BRCA genes. What the scientists are looking for in the lab is a change in the sequence of the gene. So the genes, as I said, that we have 21,000 genes, and each of them is a unit of inheritance, and each of these units is inherited individually. So I think another sort of sometimes misconception is that people think if they look like their mother, or they look like their father, or act like their mother or father, and the mother or father carries a mutation in a cancer predisposition gene, that they will have inherited it because they're so much like their parents, that particular parent. But that is not the way the genes are inherited. Each gene, each of our 21,000 genes, is inherited independently. When the scientists are looking for a mutation, what they're looking for is a change in the sequence within that gene, within the code of that gene, if you like, which has led to the gene's function being affected. And sometimes people think of it as, if you like, a spelling mistake, which means that the sentence you're reading no longer makes sense. And so the rest of the story, if you like, doesn't make sense. That's a little bit like what the scientists are looking for when they're looking for a mutation.
Okay, so everybody's got, as you said, the BRCA1 and BRCA2 gene. When people talk about, does the person have a BRCA1 and BRCA2? Actually, what they're saying is whether they have a mutation within that gene. And going back to what you said, you require a second hit to then make that mutation predisposed to breast cancer.
Well, the predisposition is there through the inherited mutation. The second hit in the tissue causes the cancer to occur, because whilst the first mutation, the germline mutation, the inherited mutation, gives you an increased risk. It gives you an increased risk because you need the 2 hits for the cancer to occur. If you're born with a mutation in all of your cells from day one, then your likelihood of getting that second hit and getting a cancer is much higher than for the person who wasn't born with a mutation in the BRCA cell.
That makes sense then, because otherwise, everybody who was born with a mutation in the BRCA gene would all develop breast cancer, whereas that's not the case, because you need that second hit for that cancer to develop.
Absolutely. So another area of research is why not everybody develops the cancer. Why do some people get the second hit and others don't? And again, it's an area that is being looked into, because we know there can be, for example, 2 sisters who carry exactly the same genetic change, yet one sister may develop breast cancer at the age of 31 and the other may live to the age of 70 without developing any cancers.
What is the lifetime cancer risk conferred by a BRCA gene mutation compared to the population risk?
The population risk of developing breast cancer is around 12%, 1 in 8. But if you carry a BRCA1 or BRCA2 mutation, that risk has been estimated to be up to 80%. But there's a range of risk because of the things I've just talked about. The BRCA mutation isn't the single factor that determines, whilst it's a very important factor in determining whether you'll develop breast or ovarian cancer, it's not the single factor. So there is a range in risk. So whilst we say the risk can be up to 80%, we know that if we look at individual families, in some families that risk is going to be lower, say 60% or 45%. However, that risk is still several fold higher than the population risk of developing breast cancer.
So for BRCA1, the risk of breast cancer is within a range of 60 to 80%, although it could be lower.
For BRCA1, I'd say it is 60 to 80%. For BRCA2, so originally we'd always quoted 80% as the risk, but more recent research has indicated that perhaps the risk for BRCA2 mutation carriers is more likely to be in the range of 45 to 60%. But, regardless, that's still a much higher risk than the population risk. And particularly for BRCA1, the risk is higher at younger ages. So whilst I quoted that the population risk is 12%. The vast majority of those breast cancers will happen above the age of 50 after the menopause. Whereas for BRCA1 mutation carriers, the risk of developing breast cancer compared to other women in the general population is much higher when they're in their 30s or 40s. That's not to say that if you carry a BRCA1 mutation, you can't develop breast cancer after the age of 50. You certainly can. But much of that increased lifetime risk of developing breast cancer is actually conferred at those younger ages for women when they're in their 30s or 40s. With BRCA2, we tend to see a later age of onset, but there is still an increased risk compared to general population when women are in their 30s and 40s. But much of the cancer risk is still conferred after the age of 50. The other thing we tend to see, because you're born with a predisposition to developing breast cancer, that you might well develop more than one primary breast cancer, which is different to having a breast cancer and that breast cancer coming back. So if we're assessing a woman for the likelihood of them carrying a BRCA mutation, if they've had more than one primary breast cancer, then that is an indicator that genetic testing might reveal a mutation in a breast cancer predisposition gene.
Okay, if you have a mutation in either of those genes, it increases the risk of ovarian cancer as well?
That's right. So the ovarian cancer risk, population risk, is around 2%, but with a BRCA1 mutation, that risk can go up to as high as 40 to 60%. With a BRCA2 mutation, that risk can be up to 20 to 30%.
If somebody tests positive for a BRCA1 or BRCA2 mutation and their risk of developing breast cancer, we can inform them that their risk of developing breast cancer and ovarian cancer is significantly raised. They may then say, okay, I want to do something about this. Obviously, I don't want to get either breast cancer or ovarian cancer. What are the treatment options to mitigate the risk or reduce the risk of them getting cancer?
Yeah, so if we're talking about in the context of a patient presented as a patient that already has breast cancer, then there are three options in terms of managing the future cancer risk. The first is they might wish to have the treatment as planned for their current cancer and then be commenced on a screening program, which, depending on the age of the patient, might involve annual MRI scans and or mammograms. And that wouldn't reduce their future breast cancer risk, but would allow early detection of the breast cancer. So that's one option. The second option is that they could take medications such as, if they're premenopausal, tamoxifen, or if they're postmenopausal, something like alestrozole, to reduce their risk of developing a new hormone-driven or estrogen receptor positive breast cancer. But we know, particularly with BRCA1 mutations, many of the breast cancers are not hormone-driven, they're estrogen receptor negative. So taking those types of medication would not reduce the risk of developing that type of breast cancer. So the research has shown that women who take these type of medications for 5 years can reduce their new breast cancer risk by about 40%. Then the third option is surgery. So to have a bilateral mastectomy procedure, and reconstruction options can be discussed with the patient for that. That is the most effective way of reducing the new breast cancer risk. It's important to understand it doesn't reduce the likelihood of the cancer that has already been diagnosed from returning. The risk that we're talking about managing through a bilateral mastectomy procedure is that risk of a new primary breast cancer at some point in the future.
Those strategies would apply to somebody who has not had breast cancer and have tested positive.
Absolutely. In terms of the ovarian cancer risk, at the moment, we don't have effective surveillance for early detection of ovarian cancers. So we are not routinely recommending that for patients. For those that are at high risk of developing ovarian cancer due to family history or a mutation, we would refer to a gynecologist for them to have a discussion regarding surgery for removal of the ovaries and the fallopian tubes. For BRCA carriers, that referral is usually made around the age of 40 years. For BRCA1 carriers, between 35 to 40, and for BRCA2 carriers, the risk tends to go up after the age of 40. So between the ages of 40 to 45. But of course, we have a personalised discussion with the individual. Of course, if they haven't completed their family, for example, then they will want to wait to be referred for that surgery. So the surgery for removal of the ovaries does lead to an early menopause. And so the gynecologist undertaking the procedure would go through options for menopause management. Also, it's the reason why we wait until around the age of 40. So some people might say, okay, I know I've got a mutation in BRCA1. I've completed my family. I'm 30 years old. I want to have my ovaries removed now because I don't want to get ovarian cancer because my mother died of ovarian cancer when she was 55. We can understand that, but because of the potential medical risks of an early surgically induced menopause, which isn't the gradual menopause that you would experience if you went through a natural menopause, and it's much earlier than the natural menopause, we wouldn't at that point refer for surgery for removal of the ovaries due to the risk of medical problems like osteoporosis, for example. So that's why we advise our patients to contact us when they're around the age of 40 so that referral can be made. Family, where there isn't a known mutation, of course, the other benefits of identifying the mutation are that sisters, daughters, brothers, fathers can be tested for the mutation also. So other females in the family who don't carry the mutation can be reassured that although there is a very high risk although there have been a number of breast cancers in the family, actually the main hereditary cause has been identified and they don't carry that hereditary cause. So they don't need to have extra surveillance and don't need to worry about having an increased risk of developing breast or ovarian cancer. So we can give some reassurance to those individuals, whereas those who have not yet developed cancer in the family but are found to carry the mutation, we would then go through discussing these options with them. Often people have a perception that these genetic changes can only be passed down from women, but actually there is an equal chance for both men and women to carry these genetic changes. If a parent carries a BRCA mutation, then each of their children has a 50% chance of inheriting it from them. And that is whether that child is male or female. And that goes back to what I said earlier, which is that we all carry 2 copies of these genes, one inherited from each of our parents. And if you're found to have a mutation, then you will have a mutation in 1 copy, but you'll have a normally functioning second copy of the gene. And so when you have children through your egg or sperm with your female or male, you will pass down one or other copy. And that's where that 50% risk comes from. And it doesn't matter how many children you have. You can have 2 children and each of those children will have a 50% risk, or you can have 6 children and each of those children will have a 50% risk of inheriting the mutation, whether they're male or female. It's the cancer risks that differ. So with BRCA1, men don't have implications for their own health, but men do come forward for testing to find out if they carry a BRCA1 mutation or not, because they might have adult daughters who could be at risk.
Right. And that's really important, isn't it? Because as you said, many people think that, well, I've got a history on my mother's side, but my father's side's history is not important because it's from my father's side. But actually, that's as equally as important.
Absolutely, absolutely. And there are implications for men of carrying a BRCA2 mutation. That's the other thing. So whilst the cancer risks are much lower for men compared to the breast and ovarian cancer risks compared to women, men do have an elevated risk of developing prostate cancers, breast cancers, and pancreatic cancers. The most significant risk is of the prostate cancer risk. Now, prostate cancer is very common in the general population. With a BRCA2 mutation, the risk is about doubled. So you have about a 25% lifetime risk of developing prostate cancer. And that risk is still mainly conferred above the age of 60, but we do occasionally see cases of prostate cancer in men who carry BRCA2 mutation even as young as when men are in their 40s. And the other thing to say is that whilst we know that prostate cancer is unfortunately a common disease, actually on the positive side of it, many men require monitoring, but not necessarily very invasive, particularly men who develop it at an older age, don't necessarily require very invasive or active treatment. But what we've seen is that men who develop a prostate cancer who carry a BRCA2 mutation can not only develop that prostate cancer at a younger than average age, but those prostate cancers can be of a more aggressive type and therefore do usually require some treatment.
Right. So if a man has been tested positive for the BRCA2 gene mutation, would they undertake some sort of surveillance at any age?
From 40. So there is ongoing research as to the effectiveness of the surveillance and the most ideal age to commence it. At the moment, in our practice, we would refer a man who carried a BRCA2 mutation to their GP and ask that the GP organise or see the patient annually to organise a blood test to measure something called the PSA level and also a rectal digital examination to see if the prostate is enlarged. If either of those baseline tests came back indicating there might be a problem, then the GP would refer that patient on to a urologist at their local hospital for further investigations.
I mean, that's really interesting, isn't it? Because I don't think we really talk about the fact that there's an increased risk in prostate cancer in men who have BRCA2 mutation. But that's a really interesting thing to know. Earlier, we talked about the genes that we would normally test to look for increased risk of breast cancer, which were BRCA1, BRCA2. I don't know if we mentioned the PALB2 as well.
Yeah, we haven't mentioned a third gene called PALB2, which we have been offering testing for within the NHS for perhaps the last 2 or 3 years. In fact, the name PALB2 stands for partner and localizer of BRCA2. So biologically, the PALB2 protein works with the BRCA2 protein in DNA repair. Similarly, mutations in the PALB2 gene can affect DNA repair and lead to an increased risk of developing breast cancer, but the risks are a little bit lower than for BRCA1 and BRCA2. So the estimates are of around a 40% lifetime risk of developing breast cancer. And just recently, a publication has suggested that there is around a 5% lifetime risk of developing ovarian cancer. So with PALB2, as with the BRCA mutations, your actual personal risk is going to be determined to some extent, not just by the presence of the mutation in the gene, but also of your wider family history. So example, if you carry a PALB2 mutation and you've had 2 relatives that developed ovarian cancer, then actually, I think that individual's personal risk of ovarian cancer is going to be higher than that 5% risk that we might sort of generically quote to those that carry a PALB2 mutation, because clearly there must be other genetic factors in that family which are increasing the ovarian cancer risk.
So at the moment in the UK, we look at BRCA1, BRCA2 and PALB2 first of all.
Yes, so PALB2 testing is not yet available nationwide as a standard test for those being investigated for a hereditary cause of breast cancer. I think there still are some areas of the country where the PALB2 test isn't widely available through the NHS.
There are other genes that we're looking into more recently?
That's right. So those are the genes that we most commonly test for in women who have a personal and family history of breast cancer and ovarian cancer. There are some other genes that predispose to development of breast cancer. So there are some other genes like CHEK2 and ATM, for example, which can increase breast cancer risk, but not to the extent of BRCA1, BRCA2, and PALB2. So those mutations in those genes roughly double your risk of developing breast cancer. And we don't standardly test for those genes in the NHS because actually at that sort of doubled level of risk, we wouldn't usually change our management for the patient. So if you are a woman that hasn't developed breast cancer but have had a genetic test and you're found to carry an ATM mutation, we would look at your family history, and we wouldn't expect to see such a strong family history. We might see one or two individuals in the family who've developed breast cancer perhaps after the age of 50. And that's why our advice to those individuals would be based not only on the genetic change that's been found, but also on their family history. And in most cases, the family history information would lead us to recommend surveillance for that individual, above that beyond through the NHS breast screening program, perhaps commencing at an earlier age, but wouldn't usually lead us to to suggesting that an invasive procedure such as a bilateral mastectomy to be of benefit to that patient when weighed up the risks and benefits to the patient of having that kind of procedure. And for that reason, we don't routinely offer ATM and Check2 testing, but genes like that, testing for genes like that are available. Then there are other high risk genes such as TP53 or P10 or STK11. Those genes do give a high risk of developing breast cancer, which is comparable to carrying a BRCA1 or BRCA2 mutation. But again, we don't standardly or routinely offer testing for those genes because we expect to see in the individual or in the family history specific other features. So testing for those genes is available through the NHS for families where we have seen specific features in the individual that suggest to us that they could carry a mutation in those genes. And that's because actually the frequency of mutations in those genes is much lower than for BRCA. So BRCA1 and 2, up to 1 in 400 of the population might carry a BRCA mutation. And in some specific populations, like the Ashkenazi Jewish population, if you have all 4 of your grandparents are of Ashkenazi Jewish ancestry, then actually your risk of carrying a BRCA mutation could be as high as 1 in 40 because of things called founder mutations. So many generations ago, due to perhaps some isolation of specific populations, the frequency of mutations in certain populations is increased.
Family history is so important in determining whether there is a risk of a genetic cause for a cancer within that family.
Yes, so family history. So until now, our practice has largely been based on family history, and it remains important. However, we're also moving to an era where we really are trying to personalize medicine and personalize treatment of cancers and cancer risk. So we are increasingly offering genetic testing for breast cancer predisposition genes to women who present with no family history. For example, a woman who perhaps presents with a triple negative breast cancer at the age of 35, or in fact any age up to the age of 60, can be offered a genetic test, which, as I say, in most places in the country would include analysis of the BRCA1, BRCA2 and PALB2 genes. For those women that have no family history, if we do that test and we don't find a mutation, then in most cases that woman's breast cancer has occurred as a chance event or as a sporadic breast cancer, as we would describe it. However, in those individuals that do have a strong family history and perhaps other features in terms of other cancers in the family at young ages, then that individual, even if they've had a test perhaps organised by their oncologist or their breast surgeon, might benefit from assessment through clinical genetics as well, just so we can look into whether other genes might be responsible. And I think it's also important to understand that even of all the genes that we have identified, they only explain a minority of the familial risk of developing breast cancer. There are over 100 or so areas of the genetic material, loci as we call them, which we know can elevate breast cancer risk. But really, at each of those loci increases the breast cancer risk a little bit. So the relative risk is perhaps 1.1 or 1.2 compared to the general population risk. But an area of great interest that I hope will be incorporated into clinical care in the near future is the area of polygenic risk scores, where we're looking at how the combination of an individual carrying those low risk factors affects their overall risk of developing breast cancer. I think once we have improved our understanding of those low risk factors and how they affect an individual's personal risk of developing breast cancer, we can deliver much more personalised medicine in terms of assessing an individual's breast cancer risk. It's also important to understand that we do have patients who have breast cancer, say a woman who's 55 with a estrogen receptor positive breast cancer, whose sister perhaps had breast cancer at 62, also estrogen receptor positive, and they've got 4 other sisters. So that individual, I can understand them thinking, I should definitely have a BRCA test because I've had breast cancer and my sister's had breast cancer. And what we would be saying is that, yes, we understand there are hereditary factors in your family, but we don't think, in just this sort of synopsis of family history that I've given, that it's likely that your breast cancer has been caused by the high-risk genes BRCA1, BRCA2, or PALB2 because of the ages of onset, because of the number of unaffected female relatives, and because of the actual histology of the breast cancer. However, we're not saying there aren't hereditary factors at play. It's more likely to be the low-risk factors, and then, these are postmenopausal breast cancer, so hormonal factors might well have played a part. So I think that, because I think sometimes it is hard for people to understand why, when they've been referred to the genetic service, why we're saying that actually a genetic test isn't going to be useful to them. And the reason for that is that we are looking at specific genetic factors which we know are not going to explain all the different types of family history that individuals present with, that many, in fact, of the family histories are going to have occurred due to the low risk factors that we can't currently test for.
Yeah, it's a fascinating area, and I think it's such a complex, and it continues to move and advance the area of genetics. And I'm sure, as you said, in the future, it'll become more of a personalized service that we can offer with, once we have more information about all of these low risk factors, for example. I guess the important thing to take away from this is that the majority of breast cancers are not genetically caused. Only 5 to 10% of breast cancers are genetically linked.
Yes, so only 5 to 10% are going to be due to a mutation in a high-risk gene. So the vast majority are not. Well, it can sometimes feel like a compliment that people think that genetics can explain so much. Unfortunately, the truth, working in clinical genetics, the truth is that actually,
let's throw more questions.
Yeah, absolutely. And there's so much still we can't explain. But my own feeling as a cancer geneticist dealing with hereditary risk factors is, it will be so great if we can understand much better the low risk factors that occur commonly. That the reason they're important is because they have been shown to be present in large numbers of the population. So we can understand those better. We'll understand why 1 in 8 women develops breast cancer, and we'll understand who we should be doing surveillance on. At the moment, every woman is offered surveillance through the National Breast Screening Programme every 3 years, commencing from around the age of 50. But perhaps that's not the way forward. Perhaps there's going to be some percentage of the population that carries genetic factors that mean that they could start later, or that they can start sooner, but, maybe they don't need it every 3 years. Maybe some people need it more frequently. I don't know. But we could the ideal is to be able to personalise the screening at population level, as well as for those who are at a higher risk, to also provide more personalised care.
Well, I can't wait until that era is upon us, hopefully in the not too distant future. Muna, thank you so much for your time. It's been an absolutely fascinating conversation, and I'm sure those who are listening out there have learnt loads and loads of useful information. So I certainly have. Hope to catch up with you soon.
Thank you.
Thank you so much once again to Dr Munaza Ahmed for sharing her expertise today in the show. If you want to check out the show notes, then head to www.mybreastmyhealth.com/episode 11. And if you haven't done so already, do hit that subscribe button, because by doing so, you'll make sure that all the upcoming episodes get downloaded straight into your podcasting app of choice. And so you won't miss any of the episodes.